Welcome everybody to the second session of the Western Pacific Climate and Health Responder course. My name is Sotiris Vardoulakis. I'm professor of environmental public health at the University of Canberra and director of the HIL network, the Health Environments and Lives Network here in Australia. It's my pleasure to moderate this session, which focuses on degraded air quality. It's the second session of the course. I'll go through some introductory slides, and then I will introduce two distinguished speakers that we have today to give a lecture and a case study. And if there is time, I will also provide some slides from an additional case study. And after that, we'll have time for questions and answers and participation. But as we start the session, let me present a few introductory slides. So the course objectives that we've gone through in the first session include increasing health professionals' knowledge, self-efficacy, and communication skills related to climate change and health, expand global workforce capacity to develop and implement educational programs on climate change and health. And the third objective is to build and strengthen an agile and informed community around climate and health education, advocacy, and policy. So these course objectives across the 10 sessions that you see here on the slides. As I mentioned, we're now doing the second session focused on degraded air quality, a very important issue related to climate change. The learning objectives of the session today include to describe the pathways through which climate change is affecting air quality, and that is fine particles, we call them PM2.5, the occurrence of wildfires and ambient respiratory irritants like pollen and aeroallergens in the Western Pacific region. Explain how these pollutants impact climate-sensitive respiratory disease such as asthma, COPD, chronic lung disease, cardiovascular disease, cerebrovascular disease, and allergic diseases. Identify populations that are vulnerable to degraded air quality, and describe how health professionals can protect vulnerable patients and teach them about the risk mitigation and how they limit outside exposure and indoor exposure to degraded air quality. And finally, the final objective is to describe the near-term and long-term co-benefits that arise from action to mitigate climate change in terms of air quality. In terms of logistics, this is a 90-minute session. As I mentioned, we have one lecture, which is around 40 minutes, and then one case study, 15 minutes, plus an additional case study we have time. And then questions and answers. Please remember to enter your questions for the presenters in the Q&A box, not in the chat box. It's a separate Q&A box on your Zoom screen. And also, I would like to remind you that the sessions will be video recorded and the slide decks and resources will be made available on the course website. Just also to remind you that the attendance is automatically recording during the live Zoom sessions, but the individual attendance is only counted if you are using your personal Zoom link, and your attendance is not counted if you join the session with a colleague's link. YouTube views will not count towards attendance. So please remember that for your attendance to be counted, you need to join the session by your own individual Zoom link. In terms of certificate of participation, you'll be awarded the certificate if you attend over 70% of the live sessions and pass the final exam with a score over 70% at the end of the course. And of course, just to remind you again that you need to use the same email address for registration in all Zoom sessions and the exam. So the exam needs to be completed. Use the same email address. The exam link will be sent on the final days of the class via email and WhatsApp. And the format of the exam is 25 multiple choice questions. And and you can see the exam only once. So without further ado now, I will move on to the session, to the lecture. Initially, the lecture by distinguished Professor Leon Guo from the National Taiwan University and also the NTU Hospital. We are very fortunate to have Professor Leon on the line today. He's a distinguished professor in environmental and occupational medicine at the College of Medicine and the Institute of Environmental and Occupational Health Sciences at the National Taiwan University. He's also an attending physician in the NTU Hospital. Professor Guo obtained his medical degree from the National Taiwan University. He holds a Master's of Public Health from Harvard School of Public Health and also a PhD in Environmental Health and Occupational Medicine from Johns Hopkins University. He's a very well-published researcher with over 400 international publications, including 10 book chapters. So it's my great pleasure to give the floor to Professor Leon Guo for his distinguished lecture today. Over to you, Professor.
Thank you very much for your kind introduction. Let me share my screen.
Yes, please.
Do you see the whole screen?
Not yet. We see now it's fine.
Okay, wonderful. It's a wonderful, great honor to be here with you and share with you the degraded air quality associated with climate change. As you already know that there is accelerated change in temperature, and especially in the past 30 years, the increase in temperature is even more severe than the previous 90 years. Juan and Mora presented the Global Cumulative Climate Hazard Index, CCHI, describing 10 indices. However, with today, there are 5 indicators that are more related to the degraded air quality: the warming, the heat waves, the precipitation, the droughts, and the fires. As you know that the report indicated an even more worse situation in the CCHI from 2017 to 2053. In those situations worldwide. How is that related to air pollutants? Let me first introduce to you air pollutants. There are primary pollutants and the secondary pollutants. Okay. The primary pollutants are PM, SO2, CO, NO, PAH, VOC. The secondary pollutants are ozone and SO4 and NO3. Why it's called secondary is because some of the primary pollutants through the sun photon will produce the ozone. And that is why the ozone is secondary pollutants. It seems very confusing. So I try to summarize into 3 kinds. One is the traffic related, represented by CO and NOx. The other one is of complex source, but more health effects noted, the PM. And then third is ozone, which is a representation of the oxidants. So remember three is probably easier. So in many countries, PM, SO2, CO, NOx, and ozone were monitored. That's why more studies can be done to document the health effects. About the climate, the heat will enhance the occurrence of oxidants. So what are the mechanisms why climate change enhance health-related air quality? Increased temperature will enhance the occurrence of ozone and PM 2.5. There's also stagnant weather conditions that will make people more exposed to poor air quality. The desert dust produces many little particles, and they go transboundary. Increased allergen due to the increased CO2 and temperature and the pollen productions, causing allergies and relative respiratory issues. And the wildfire causing increase in PM, ozone, and VOCs. So the five are the more important mechanisms, but I will explain each. So this is a study that found the relationship with between temperature and the occurrence of ozone. As you know that NO2 with the photon from the sunlight will become NO and the O, and the O plus oxygen is O3 is ozone. And so with the heat will increase the reaction, and that's why you see higher temperature to be highly associated with increased ozone in several regions. This is another study in Leipzig, in Germany, in which a heat wave caused elevation of ozone, and that temperature, 33 degrees, is becoming more and more seen in many places in the world. What does ozone do? It causes daily mortality change. So the same day with higher ozone, the same day the mortality is increased. This is an investigation in 17 cities in Asia, and we found that the ambient ozone is associated with an increased risk of mortality. So in Taiwan, Korea, and Japan. I'd like to introduce also Professor Kim and Honda from Korea and Japan. That look like 40 ppb of ozone is where you see an obvious elevation in mortality. The other situation is air stagnation. So the air stagnation, according to National Weather Service, is a meteorological situation or build-up of air pollutants. And look at the mechanism. It is because the warm air acts as a lid and hold the cold air and the pollutants near the ground. So people, so the overall pollutants will not increase, but people are more exposed. And it's not easily cleansed by the breeze of every day. And therefore, people are having higher exposure. The National Weather Service will pronounce air stagnation advisory when this occurs. Is it related to climate change? The Climate Data Center found that the late 20th century air stagnation frequency is indicated here. You will see the yellow, and then followed by the green, followed by the light blue with higher stagnation. However, the estimation for the late 21st century, there seems to be lots of increase in the stagnation occasion. And you will see that in the Western Pacific region, a high risk as well. The other mechanism is a desert dust. So the increase in temperature and shifting precipitation pattern reduce the soil moisture and causing the increase the deserts or the desertification process. The total dust emission contribute 1,000 to 2,000 million tons per year, which is a half of the total aerosol. And that dust can be carried transboundary. So in Asian dust from the deserts go to Japan, South Korea, and even cross the Pacific to the United States or the Arctic. As you will see that the desert storm from Sahara is carried long way through to North America. It's estimated that given the fluctuation, the overall estimation of dust mass loading is increasing gradually up to the end of the 21st century. So we are probably going to face more dust mass loading or more desert dust in the future. Of course, please note that the regional variation and uncertainty exist. What does PM 2.5 or the particulate that's inhalable and reaching your alveoli, what does it do to people? This is a study using a multi-country, multi-city approach, including 652 cities from 24 countries or regions. What I found is that with increasing PM 2.5, there's increasing daily mortality. That's immediate day related to the PM 2.5. So the more short-term effect. And if you reduce the PM 2.5, the mortality is reduced. And it's very noteworthy that it seems not to have any threshold. Even if you are lower than 10 microgram per cubic meter in the PM 2.5, further reduction will further improve the health and reduce the mortality. So I think this is worth noting. Who are susceptible? the elderly, those with chronic disease, especially cardiovascular and respiratory conditions, are more susceptible to PM 2.5 mortality. There are other effects. For example, this is a review on PM10 on asthmatic children, which is a meta-analysis. They found that for each increment of 10 microgram per cubic meter of PM10, there was increase 2.8% in asthmatic attack, including some increase in cough and reduction in the lung functions. A real life example is from the Beijing Olympic 2008. Beijing has some condition with air pollution. This is immediately before the Olympic. This when the Olympic starts. With great effort, like reducing the industrial emission and the vehicles, they were able to clean up the sky. A study at that time on 38 children, mean age 10.6, and used the Excel nitric oxide, ENO, as an acute respiratory inflammatory biomarker. What they found was that this is a line before and after. So what they found was the reduction of black carbon by 60%, PM 2.5 by 67%, and as a result, the ENO was reduced by 30%. Another study conducted the same time found 46% reduction of asthma outpatient visits. So this indicates that PM 2.5 is strongly related to the attack of asthma. There are many causes of asthma, but you want to do asthma occurrence first and then attack. So airway remodel, airway responsiveness, oxidative stress, and immune response all contribute. For example, the airway injury and inflammation, and the immune response is a Th2 phenotype that make you susceptible to allergens and causing sensitization. Where does AP come in? So it would cause enhanced responsiveness in the airway and the oxidative stress and induce more allergens. And when a person becomes asthmatic, they also cause attacks. The other condition related to air pollutant is the COPD. The PM 2.5 and ozone are related to acute exacerbation of COPD in meta-analysis. For each 10 microgram per cubic meter in each pollutant, there was increase by 3% and 2% of the attack. These are the acute, but it's also important to note the longitudinal effects of PM 2.5. So a study showing the relative risk of disease mortality in the Global Burden of Disease investigation is published in Lancet 2020, and the appendix shows the relative risk. So I try to graph them together using the same scale So 1.4 here, 1.4 here, and 1.4 here. So it's easier for you to compare the effects. So this is a long-term lifetime mortality as related to lifetime exposure to PM2.5 up to 100. You will see a dose response curve. Some are curved, some is quite straight. But lung cancer, ischemic heart disease, stroke, COPD, type 2 diabetes, and lower respiratory infection are all related. And again, there seems to be no threshold. You can trace the concentration to 0, and anything anything higher than 0 seems to be having some effects. With the relative risk and with the number of people who are exposed, you are able to calculate the attributable risk. So sorry for the busy slide here, but you can look at them later in the slide deck. So we calculate the population attributable fraction of lung cancer, COPD, ischemic heart disease, and so on, due to the PM2.5 from 2000 to 2020. And in the world, there seems to be improving PM2.5 from 2000 to 2020. The lung cancer, COPD, ischemic heart, stroke reduced. I also put Asian regions and Western Pacific regions in blue color, so you can easily look at them. I have to stress though, even it's improved, the attribution of lung cancer to PM2.5 continue to be present. And further efforts are needed. Let's talk about factors that contribute to risk. So we know the natural hazards easily. However, in environmental conditions, you have to have exposure to cause hazards. So the exposure means that the people or the property need to be present in hazard area. And then you have to consider vulnerability or the susceptibility. So the susceptibility of individual or community or the asset or system is highly related to the risk. Taking a condition as allergies and asthma as an example. So this is adapted from Agachi et al. And the climate change, like thunderstorm, wildfire, and dust storms, heat waves, are the natural hazards. And you have to be exposed to them to cause the health effect. And there are susceptible people. This Agachi and co-workers indicate it's individual factors like epithelial barrier defect, inadequate immune development, microbial dysbiosis. And the vulnerables are the group of people, for example, elderly with comorbid conditions like a respiratory or cardiovascular, young children, pregnant women are quite vulnerable. And low literacy or education, low income, and outdoor workers are all susceptible. And with all these combined, allergies and asthma can occur with the air situation related to climate. One of the examples is the allergic condition. So at starting year 1, you will see atopic dermatitis and food allergy, and later they actually subside by teens, most of them. And then this is followed by allergic asthma, which could subside, and followed by allergic rhinitis, which will probably last for the whole life. This is called atopic march. So increased temperature are related to asthma and allergic rhinitis and other atopic conditions. What are the mediating factors? This is from Kelly and the co-workers. They described the exposure to extreme heat, the air pollutants, the flood, and the fungi, and the pollen are potential factors, and they are related to climate change. I like to admire this investigation, which study the pollen season and allergic sensitization during 27 years in Liguria, Italy. They noted an increase in temperature of greater than 30 degrees and also average temperature, which is related to the duration of pollen season of several plants. And the total pollen counts in the 27 years seem to be increasing. As a result, the number of people sensitized were increased in the 27 years. This is in Europe. What happened to Western Pacific? This is a study in Seoul, which show, actually look at the red color, which is the pollen grain, which is increased over the past 25 years. As a result, the sensitization rate to pollen in Seoul metropolitan area are generally increased in the 25 years of the study. I'd like to mention about outdoor and indoor. No matter pollen or PM 2.5 or the traffic-related air pollutants, there is some protection from indoor against those pollutants, but there is also ventilation and penetration, and you cannot totally avoid those pollutants to get into the indoor environment. For example, if you get everything closed, the door and windows closed, you still get about 0.8 as a ratio from indoor to outdoor PM 2.5. So 80%. When it's highly polluted, it's probably a little safer staying at home with everything closed and the air cleaner or air purifier on. However, there are also indoor sources. One of the indoor sources is biological agents like mold, dust mite, and bacteria, and that are related to precipitation and storms. So these are also related to health outcome as well. For example, atopic dermatitis is related to mold growth. Remember, indoor air pollutants also linked to other health effects like heart, cardiovascular, respiratory, like asthma, and also linked to cancer. This is a study in Taiwan using the Taiwan birth cohort study, and they found mold wall fungus is highly related to atopic dermatitis. Situations like this. What happened to climate on the fungi? This is a study for the whole year from 2013 to 14. What I found was increased fungal spores during the hottest season, June, July, and August. And the number of fungal spore is highly related to temperature and relative humidity. So with increasing temperature, it is possible, but not totally sure, it's possible fungal spore can be increased in the future. Fungal spore, when you study the lung function, fungal spore is related to reduced lung function, especially when the cladosporium spore is greater than 1,500 spores per cubic meter. So there is a sudden drop in the lung function. I'd like to mention a little bit on the wildfire. So the temperature increase will cause the drier condition, and the heat wave dry out the vegetation, and strong wind will spread the fire. Change in precipitation will cause local droughts and dried forest. And the fire season can be extended, and the frequency of lightning will ignite the wildfires. Of course, the above-mentioned mechanisms are varied in different regions in the world. Let's take LA, a recent LA fire as an example. They do have prolonged dry period and a very famous Santa Ana wind that dry out the vegetation. And they have flammable vegetation. The people expand their living environment, so they are very close to the fire. And there are very special lack of water issue at that time. After the fire, you will see, I say during the fire, that you'll see smoke expanding. The Copernicus website shows you the global fire monitoring results, and you will see hotspots in many places. Taking Western Pacific, you'll see many hotspots. The MCC study group find PM 2.5 related to wildfire in quite a few places. But what they found was also the increased mortality, including all-cause, cardiovascular, and respiratory mortality. So with the increase of 10 microgram per cubic meter increase, they will see only 2% increase in all-cause mortality. But they also attribute to 0.6% of all mortality in all-cause mortality and cardiovascular and respiratory mortality. So sometimes you never feel that the wildfire is near us, but it also exerts effects on our health and the mortality. The same picture for ozone, and also a very similar attributable percent by wildfire ozone. So this is a MCC group. I'd like to mention the PM 2.5 daily mortality by Professor Kang's group, and the wildfire study by Professor Guo's group. We are the same Guo, but we are probably not related, at least for 3 generations, I think. This is the leader of the MCC study, Gasparini, and this is myself, a little younger. And they later, due to COVID and other conditions, many meetings are carried out online. One example, the Australian Black Summer bushfire in 2019 to 20. You will see this is Southeast Australian. You will see the fire spots here, and as well the smoke that are spreading even as far as the New Zealand. And people surrounding are at higher risk, especially in the pregnant woman, infants and young children, and the caregivers of the infants. I am 1 minute over time. May I have 2 more minutes to finish it?
Yes,
Okay.
please.
So you can see the slide yourself, but these are very susceptible people. A study carried out in the caregivers in the highly involved by the wildfire, Vardoulakis in here, and comparing to others, the caregivers are more stressed, more difficult to be patient with the children, and they struggle more with anxiety. When it comes to the children situation, the children not wanting to be put down, only wanted the caregivers to hold them, wanted more of their attention, and not wanting to be separated from the parents, and cry more. So they are mentally or physically affected. One study found that the congenital conditions were related to in utero exposure. So from exposure of 3rd to 8th week of gestation, exposure to PM 2.5 is associated with 21% increase in congenital heart condition. And also, its hypospadia in the boys will increase by 29% if they are exposed to PM 2.5 during the critical period. So when there is a wildfire around you, do you want to extra protect the children and the pregnant woman? I think that's very important. The study authors summarize the health conditions: asthma, gastroenteritis, injury, pregnancy, complication, feeding difficulties, mental health, child special needs, and caregiver impairment, behavior concerns, and domestic violence. I had an opportunity to visit a nearby place. It's Budawan National Park, New South Wales. And you can see a clear difference in the woods. These are not burned, these are burned. So, and they are quite near to the residences in people. But so the community residents were trying to establish fire-resistant refugee in here, feature water storage, huge water tanks, food and life requirements, first aid kits, and HEPA air filters for them to survive the wildfire. Maybe this is one way to protect the situation. So, in summary, the climate change causes situations which change the air quality and cause health effects. We use adaptation trying to avoid the health effects, and maybe it's also important to prevent such effect, such climate change to occur in causing the poor air quality. So how do we learn for adaptation? It's still a long way to go. Any effective measure for person, susceptible people, and the public. So these are more adaptive. This one person is not as adaptive. I'd like to thank you for your attention. And if you have not been to Taiwan, please come. This is one place in Taiwan, this Taipei 101. I'd also like to mention, in any metro, even if it's crowded, you always find empty courtesy seats. And I think that's an important thing for Taiwan people. Thank you very much.
Thank you very much, Professor Guo. That was a fantastic presentation. I would like to move on to the next presentation, and of course, we'll have time at the end for some questions. So I would like now to introduce our next speaker. I will put again the introductory slide on the line on the screen. So our next speaker is Professor Pham An, who holds a medical degree and a PhD degree in pediatrics from the University of Medicine and Pharmacy at Ho Chi Minh City in Vietnam, and serves as the president of the Vietnamese Association of Family Medicine. He has a lot of experience in research and practice, and he has spearheaded international collaborations to develop family medicine in Vietnam, including also projects in the US, Europe, and Australia. So we're very fortunate to have Professor Pham An with us today. Professor An, if you would like to share your slides, the floor is yours. Thank you.
Yeah, thank you, Professor Sotiris. I would like to share my presentation.
Okay, can you please share your slide?
Yeah. Yeah. Good morning, dear our ladies and gentlemen. I would like to present my case study. The first, as we know, the climate change-based presentation from Professor Leo showed us that they have a profound impact the air quality. They also contribute to the increase of current of ozone pollution, PM 2.5, wildfire, desert dust, and the other respiratory irritants. Our region, Western Pacific, is particularly vulnerable due to the rapid of urbanization, industrialization, agent dust, and climatic shifts that worsened air pollution and is associated health impact almost in the aging people and children. This session, we will explore the pathway of air pollution, information is health consequences, and public health strategy to protect the vulnerable population. As we know, we move from global health to planetary health through One Health. What does it mean, One Health? One Health is the disease they transmitted from animal to the human, such as COVID-19 pandemic last 2 years ago. And now I would like to take a presentation of in one Asian city. In this city, we experienced a high level of PM2.5 pollution due to traffic congestion and also the industrial emission. Recent study, we have shown the significant respiratory impact on school children, as we know, who are exposed to air pollution. And also, the protective measure like a mask wearing, they remind repeated between school children and the caregiver. And now, our key learning objective is that we try to analyze the impact of air pollution on children's respiratory health. The second one, we evaluate the effectiveness of personal protective measures like wearing the mask. And the third one, we developed the evidence-based policy recommendation for reducing exposure. We look at the table 1. We have the emission source from coal combustion, biomass burning, fossil fuel combustion, vehicle traffic, and also industrial emission. All of them, we can see that the PAH, that the polycyclic hydrocarbon, aromatic hydrocarbon. The PAH osmote remained on the emission source. And we can look at in the next, in the right, the middle, the ultra-fine particular exposure, they include of metals, PAH, iron, and bacteria. They contaminate, and after we inhale, they go inside to the lung. They cause the inflammation through the oxidative stress, and also they cause the respiratory disease. Besides it, they have the other impact to cardiovascular, neural toxicity, and as the presentation from Professor Leon, they can cause the carcinogenicity, mutagenicity, and epigenetic change and toxicity. It's very important for our future generation. And now we can look at the picture can make clear how the mechanism to cause the damage for all the life cycle. You can see in the children, in the adult and aging population. And very important that from pregnant women, they can make many impact and until our children. And how? And now we can look at the PM2.5 components. include three components: inorganic component, organic component, and biological component. And as the picture shows that all of them, they can have the impact on children's health. It's very important for our younger generation. And now that our case, we have a scenario. We have a 10 years old boy in one Asian city, frequently experienced to wheezing, sneezing, shortness of breath. His parents report that he struggled to concentrate in school due to difficulty breathing. He lived near a major road traveled by motorbike and rarely wear his mask. His school participates in a study to measure the PM2.5 level, which frequently accept WHO air quality guideline. And we have three discussion points. For the first one, how does PM2.5 affect children's lungs compared to adults? We think about this one. And we have evidence that children are more vulnerable to PM2.5 than adults due to their developing lungs, higher breathing rate, and weak immune system. That's the first point. And consequently, reduce children exposure to PM2.5 is essential to prevent chronic lung disease and also respiratory infections. The second question we should think about, should he be required to wear a mask all the time outdoors? Yes or no? We have, the pros that the mask should be worn on high pollution day. What does it mean? When we have the AQI above WHO limit, that are our recommendation. And the second one, actually, wearing the mask is not a long-term solution for reducing air pollution. At the source is the key. That means it's a very important preventive solution. And the third question, we think about this case, what the community intervention can help to reduce exposure. I think all smart thoughts, actually, we think about this for a long time. And also community-based intervention, like education, improve the planning, and stricter policy can significantly reduce children PM2.5 exposure with the many evidence. The second one, we need to collaborate a bit among the government, school, and family. Is necessary to create a long-term air quality improvement and also the multidisciplinary collaboration. And the next one, we can clarify some issues. First one, we talk about the PM2.5. And what is PM2.5 and why it's harmful to the children's lungs? As we know in the previous presentation from Professor Leon, it's so interesting presentation. And I emphasize that PM2.5 is that a particular matter, very small alveoli of the lung. And the mechanism I showed in the previous slide, that is a PM2.5 is extremely dangerous to children's lungs. due to its small size, ability to enter the bloodstream, and long-term respiratory impact by oxidative stress and cause inflammation, long-term, short-term, and long-term, and also the allergy. The second one, how to confirm this phenomena? The black carbon deposit in alveolar macrophages serve a biomarker of air pollution exposure. It's very important indicator that increase the risk of lung disease and inflammation. And also the protective measure like air filtration, mask wearing, and policy intervention is necessary to reduce the children exposed to 2.5 pollution. The PM for 2.5 inhaled, they can cause the black carbon deposits in alveolar macrophage. And now we look at the outdoor air pollution, and we also deal with the indoor air pollution. As in the picture, we have the indoor air pollution. And also, it's very important in Asian country that the mosquito scene, when they burn, and also the scene they burn in for the ancestor ceremony, and tobacco, all of them, they make a huge source of indoor air pollution. It's very important. It's a new one we recognize through some research. And now, we have one other research that traffic-related air pollution and school children health. We published in the paper, and also the case finding that the children in urban area has a higher inflammation marker. As you see in the right way, in the macrophage, the black carbon in the B and also in the C. You can see the black carbon in the macrophage. We took the sputum and to observe then in the microscope and find out that the children urban has inflammatory marker, and also the air pollution exposure corrected with reduced function and mandatory mask wearing. During high pollution day will subject it. And we have many research to do this. And the mask can help the protection, but should not replace for the air quality solution. But the health measure should address both short-term and long-term strategy. And evidence-based, we show that the PM2.5 exposure linked serve long-term effect. And also, children and caregivers perceive air pollution risk differently due to cognitive development, access to information, and cultural factor. But the health strategy should focus on raising awareness among both groups and improve protective behavior. And the role of the family physician, many on here, you can look at our picture, but focus in research. We need more research, implemented research, and translational research. And the other alternative perspective, we should involve strict air quality regulation. And air pollution have a direct impact to children's health, especially in urban environments. And preventive measures like mask wearing help, but policy level solution is necessary. A combination of personal protection, infrastructure improvement, and policy enforcement is the key to combating air pollution. We have some insight. We argument about priority economic growth or environment policy. It depends on the we balance among two priorities. Yeah, and now the climate change adaptation and mitigation must be part of training program and CME for health and workforce. We need to more clinical evidence with research such as treatable fracture is a new approach or not for balancing between economic growth and environment policy. And also, actually, multidiscipline collaboration with big data and artificial intelligence is very important in primary care in climate change adaptation and mitigation. Smart here, we have the Internet of Things combined with e-mentor and also the M-mentor or electronic EHR and mobile health. Thank you very much for your pay attention. Yeah.
Thank you very much, Professor Phan Lian. That was a fantastic presentation. So we have both speakers on the line at the moment. We're receiving questions through the Q&A box. I would like to share a few slides, and then we'll have time for questions. There were a number of questions around interventions aiming to reduce exposure to air pollution. And I would like to highlight a study we published recently in a scientific journal. I hope you can see my slide. So this is a study we published in the Science of the Total Environments focused on wildfire smoke and evidence-based interventions. We reviewed the scientific literature. We identified 33 studies which focus on interventions related to communication and behavior, ventilation and filtration, and respiratory protective equipment. And we have a summary of those different types of interventions in relation to communication and behavior. That includes communication campaigns. So here in Australia, there has been campaigns run by Asthma Australia during Asthma Week. There are other campaigns. And there are also smartphone applications, including health messaging during periods of high smoke pollution. They have some benefits and potentially some trade-offs. So smartphone applications can be effective, but not everybody has access to smartphone or a reliable coverage all the time. So the uptake could be sometimes restricted. The other type of interventions are related to ventilation and filtration in buildings. That includes natural ventilation or mechanical ventilation, opening and closing windows, using in-house ventilation systems with filtration, and also using portable air purifiers with the HEPA filters, which are very effective in reducing exposure to fine particles like PM2.5. Again, these interventions have some benefits and disbenefits. As I mentioned, HEPA filters can reduce exposure to fine particles very substantially. But at the same time, they can be expensive. There is an upfront investment for purchasing this type of devices. And also there is electrical consumption issues, potentially some noise issues, especially in bedrooms and classrooms. But there is a clear potential for this type of equipment to reduce exposure to fine particles in particular, but also to some gaseous pollutants. There are other interventions also that were examined at the moment. For example, creating cleaner shelters in public libraries or other public buildings where people can find refuge during periods of very high air pollution. The other type of interventions, which both speakers refer to, is respiratory protective equipment like face masks. They have benefits and disbenefits. The main benefit is that they can reduce exposure very substantially. If we're talking about the best available masks, these are N95 or P2 masks, which fit well around the mouth and nose. They can reduce exposure. Other masks, clinical masks, are not as effective. And of course, there is limited availability of masks or mask designs for children or people with different facial features. So again, there are some limitations there. But overall, there are a range of interventions. They can reduce exposure. Here you can see a summary of the media campaign, social media campaign we ran, focusing on information about exposure to air pollution, staying indoors during episodes of higher pollution, closing doors and windows, checking air quality using a trusted smartphone application, using an air purifier with a HEPA filter, and avoiding pollution by using a mask, an effective P2 or N95 face mask. There is a fact sheet based on this publication. You can find it online. So the article led by my colleague, Dr. Nigel Goodman, is here, published at the Science of the Total Environment. Please visit the HIL network website. You can find more resources about protective action to reduce exposure to air pollution, including the publication and fact sheet that I have just mentioned. So with this brief note, I would like to open the floor now to any questions from the audience. We have around 850 participants in the session. I know there have been some issues with joining the session online, but we have a range of questions for the two distinguished speakers today. So I will start with some questions addressed to Professor Guo about effective adaptation interventions to mitigate impacts of air pollution. So I mentioned some interventions. Professor Guo, I would like to hear your opinion about these adaptation measures in relation to air pollution exposure.
I think, like I mentioned, it's important to avoid the exposure first if it occurs. In an individual point of view, it will be easier if you don't get exposed to traffic-related pollutants, ozone, or PM 2.5. Air purifier, like what you mentioned, is a very efficient approach. However, it's very expensive, and it's probably not very good for all the general population. So my personal feeling is that the overall quality of air quality criteria need to be tightened, and it is a big job for the government, but you have to try to convince the policymakers that the saving in life and health may be worth the efforts of reducing the exposure. So I guess the other thing is exercise increases the mini ventilation. So when there is known or predicted or forecasted air pollution coming, you may want to avoid active exercising and find another time for your exercise. And you may want to, there are also ways to avoid a highly polluted area, to walk or drive other ways to work, or to other ways of communication, commute, so to avoid exposure. I was mentioned about the avoidance of exposure to this point. There are ways to reduce susceptibility, but it's a little more complicated, and it's highly dependent on different medical conditions or the individual's characteristics. Thanks.
Thank you very much, Professor Go. Can I extend the question to Professor Pham Lian in relation in particular to face masks and applicability in children? Do you think this is an effective intervention? You're muted, sorry.
Sorry, can you repeat? Yeah, with wearing the mask and children?
That's right. So it has been suggested that face masks can be effective, but might not be a practical solution, especially in children, and especially when we have periods of extended periods of higher pollution.
Yeah, thank you very much for so interesting questions. As you know, for in Asian countries now, also when you go around the road, the picture of children wearing the mask is very, very popular, and also not N95 mask, or the surgical mask. It's a very convenient for the children when they go in the traffic jam or exposed with the outdoor air pollution. I think it, as well, we know that in our presentation, it's the short term. It's very important, and short term can protect our children in Asian countries, because in Asian countries, as you know, they have sometimes they spend the time in the road, because in Vietnam, the parents usually to bring the children to go to school and in a long time to expose. And wearing the mask is very important and short-term preventive measure. Yeah.
Thank you. And of course, there is the co-benefit of reducing exposure to respiratory infections, viruses, etc., as we saw during COVID, the COVID pandemic. So there are some benefits there, and they're not as expensive as the air purifiers.
Yeah.
So there is another question in relation to air pollution. When do you think air pollution reaches emergency levels, when people really need to take protective action? Where would you draw the line? Maybe if we have a Professor Guo coming first, and then Professor An.
I think this is a very dynamic question, because the answer is also dynamic. The air pollution criteria for example, ozone or PM2.5 or NO2 actually are becoming tighter and tighter. And WHO now recommend much lower criteria, like us comparing to a few years ago. And the scientific evidence recommend actually maybe there is no threshold. So the criteria is tighter, but also the acute effect level are more detected in population. So I would say that I don't know if there is a standard answer for that. But for example, PM2.5, there are increased occurrence of death or mortality in certain level. So like what I presented, like for each 10 microgram per cubic meter, there is an increase by certain percentage, not very large, like 0.5%. That's the same day death, 0.5%. How is that important is requires a society to decide. So if you have an increase of 50 microgram per cubic meter, from the 10 microgram per cubic meter to 60, then you will say the increase of mortality could be like 5%. How much? No, like 2.5% already. Do you want to be careful about that concentration? I think that requires the society to decide. But for myself, I would try to avoid outdoor exercise when the PM 2.5 is 60 microgram per cubic meter. That's for myself. Not no. So if you have to go to work, your criteria may be a little loose. If you going for recreation, then you can be a little more strict. I don't think I can answer the whole question, but it's just some thoughts.
Okay, thank you. That's very useful. And actually, we had a lot of discussions here in Australia during the Black Summer fires of 2019, 2020 that you mentioned in your presentation, whether children should stay indoors or go out and play. There's obviously a trade-off. We want kids to be active and exercise, but at the same time, we don't want them to be exposed to high levels of air pollution, especially during wildfire smoke episodes. Can I ask Professor Lian about children and their exposure to air pollution? When do you think we should draw the line and say, okay, it's better for children to stay indoors rather than play outdoors in the playground during school time?
Thank you very much for your interesting question. The same, I agree with Professor Leongo. We need to avoid the children, as we know that in our study, we confirm that when the children are exposed to the air pollution, PM 2.5, they increase the black carbon in macrophage in the lung. We have a very good evidence. So we need to advise them. But something, as Professor Leongo said that making the policy is very difficult point. Also, in the family medicine, family doctor, we can advise our children that we educate the parent to how to use the AQI map. They look at the map and they will aware that this day is the red day, and they try to give the children the advice. Try to expose in the road or wearing the mask when they go around. And also, I agree with Professor Leon to avoid exercise, in the outside. But also in the school, we need to green space, increase to plan the green space for them. That also the other method to reduce of air pollution for PM 2.5. And also for children, the indoor air pollution is so very important for children and elderly, because as you know, in Asian countries, many generations we live in the same house, and burning the scene for prey or mosquito scene burning or smoking is also the very important source for indoor air pollution. It's very important. The same with outdoor air pollution. Thank you.
And thank you very much. That's a great answer. And I would also add that the air quality index, when it's over 300 roughly, then it's within the hazardous category. So this is there are different ways of calculating the air quality index in different countries, but broadly speaking, anything above 300 is a hazardous air pollution level. And as Professor Go mentioned, also the World Health Organization has reduced the guidelines the limit values for PM 2.5 from 25 microns per meter cube to 15 microns meter cube for 24 hours exposure to fine particles. So there is a realization that even relatively low levels of air pollution cause a health effect, which can be avoided if we improve air quality, if we reduce our exposure, especially in children.
Yeah, but I would like to add more about we need to do translational research. The reason why, because we are the scientific, usually we use the jargon term for the parent, for the teacher in the school. You see, they didn't know, they didn't understood what is the PM 2.5. And we need more of the look like translational research. That means we use the marketing agent to translate our jargon scientific term to the parent, to the school teacher, for easier to understand. That means that we can help them to prevent, especially in the days of the air pollution. You see, sometimes we talk that they look at the AQI, but they didn't know. Also, we have to teach them, and that's a very important emphasize in the future. Thank you.
Thank you. I think this is an excellent point, that we need to increase translational research and increase the awareness about air pollution, but also increase health literacy, environmental health literacy, and understanding of the different terminology, of the different terms used in air quality management. I would like to ask you about transboundary air pollution, which is one of the questions that was put in the Q&A. How do you think we can control sources of air pollution that are in different regions or in different countries? And we know that this is a problem in Southeast Asia. It's a problem also in Australia. We've seen that air pollution from wildfires, from agricultural burning, is traveling very long distances. Can I have some final remarks from you on how we can best avoid exposure to transboundary air pollution, which is difficult to control? Maybe starting with Professor Guo and then Professor An, and any other concluding remarks.
Oh, that's toughest question, I would say, for today, because it is very hard to attribute the amount of transboundary pollution, and especially in the desert dust situation, which occur a lot. So it is not quite sure how you can accommodate, how you can try to reduce such exposure, and whether you will hold the origin country as guilty for the transboundary pollution when it's a little more natural or it's from the deserts. So I'm not quite sure. There are some pollutants that are from industry or other sources that are more obviously man-made. I think they can probably be calculated and determine how much contribution is from the other countries. But no, gee, this is a tough question. I don't know how to handle it.
Thank you. And Professor An, Vietnam is also in the mix. Obviously, there is a lot of transboundary pollution from the region. What do you think? You mentioned translational research, collaboration, international collaboration, I suppose, is the key. What else would you suggest?
Yeah, may I have the idea? Yeah, thank you very much for your so interesting questions. In the presentation from Professor Leon, we have two main major based on the issue. The first, preventive issue. for privacy issues, they related directly to the government policy, every countries, you see. And for the government policy, they have to balance between the economic growth and also environmental protect. It depends each period, each policy. And they need more of evidence, of research, of evidence. And now you see that osmote, the evidence from us, we wrote in the jargon, osmote in the jargon or scientific term. We need more policy, political research for the policy or stakeholder. They understood clearly. And now you see we have many research on super layer. Look like you have the air pollution, the mortality. Even though we have the time series or we have some statistical method to confirm they have some relation or consequently. However, we need some cohort study. You see, we need some cohort study to make strong evidence to convince them to balance between two and how to choose the first one. And the second one, we need to multidiscipline collaborate. Now, for example, we have a clinician. Look like in our group here, we are a strong group because we have a collaboration between clinician, family medicine, a primary care doctor, environment scientific, and policymaker. Also, we can help together to work together. It's a strong point I emphasize. And for the second one, for the population, they have to adapt and to mitigate with the climate change. And how? As we know that we have to educate them first. And also we need a small research translate to in their language to educate them. That means the health literature, as Professor Sotiris mentioned before, is very important for us now. We have many of scientific research. However, when we ask the population, they smile. And something they ask the other question, you see, that's a big problem now I would like to emphasize. And not for the parent, not for the school teaching, but also for the health professional. The other people, they didn't remain aware about the air pollution. You see, we need to transfer the jargon term to them, you see. And for the mitigation, for the children at the line, we have taken more guideline or the apps in the mobile phone. They react to them with the AQI integrate inside. For example, for the children with asthma, if the parent look at the apps, they say they can more easier to take the meteorological information in television, not so easy to understand. Thank you.
Thank you very much. That's a great commentary. We need more interdisciplinary collaboration. And of course, it's important to develop the evidence base and translate the evidence base into policy, advocacy, and action. So, and this is the role of health professionals like the audience today to raise awareness and promote evidence-based solutions to improve air quality and reduce exposure. So at this point, we're over time. I would like to thank very much Professors Leong Guo and Professor Lian for their excellent presentations. I would like to thank the team at Columbia University, Dr. Danielle and her team for organizing the session, and thank you all for participating. I will share with you the link for your feedback, so you can see your feedback about the session. And with this, I would like to close the session, and please feel free to contact us if you have any further comments or would like to follow up any of the points of the conversation today. Thank you all for your attendance.
Yeah, thank you. Bingo. Thank
Bye-bye.
you.
Thank you.
Yeah, bye-bye. Goodbye. Thank you.
Thank you very much. Bye-bye.
Bye-bye.
Thank
Yeah.
you.